Hello everyone. Today we'll discuss about neurocysticercosis. Here we'll discuss its etiology, life cycle of the organism, clinical features of neurocysticercosis, its stages, investigations and management according to new recommendations of IAP. So starting off with its etiology, it is caused by the organism that is T.solium. That is a pork tapeworm. So going on to its life cycle, the definite host here is man, the intermediate host is pig, and the infective stage. How does the man occurs infection is by the larval stage. That is called as Cysticercus cellulose here. Okay, so man acquires infection by the eating undercooked pork. The undercooked pork that consists this larval stage, that is Cysticercus cellulose. So once the man ingests this larval stage, in the small intestine of the human beings, this scolex will exvaginate from the muscle of this undercooked pork, and it will get attached to this scolex will get attached to the intestine of the human beings. So once it gets attached or anchors to the intestine, it acquires all its nutrition from the man, that is from our circulation. Then it develops into a adult worm. Then it develops into this adult worm in the small intestine. It lays egg. These eggs are being passed in the fecus. So this fecus will contaminate the surrounding soil and water. So once it is being contaminated, that which is being ingested by the pig also acquires the infection. In the pig, then duodenum, this egg, that is the embryophore, this embryophore will rupture and it will release this oncosphere. This oncosphere will penetrate the intestine of the pig, and it will come to the systemic circulation, and it will reach the striated muscle of the pig, where it will form the Cysticercus cellulose, that is the larva in the muscle of the pig. This is the life cycle in the pig. So not only by eating undercooked pork, the man can also acquire infection by eating or drinking the contaminated food and water that is contaminated with the egg of the T.solium. So this is also another way how man acquires infection. This is the life cycle of this T.solium. Next, we'll go on to its presentation. How does this cysticercosis gets presented? This can get presented as, first one is as subcutaneous nodules. Second, as muscular cysticercosis. Third one, it is neurocysticercosis. In neurocysticercosis, based on its anatomical location and clinical presentation, it can be further divided. So it can be further divided into 5 types. First one is parenchymal. That is when the cysticercosis is formed in the brain parenchyma. It first is parenchymal neurocysticercosis. Second is when its location is in the intraventricular region. Third, in its subarachnoid space. Fourth, in spinal. Fifth, in the ocular region. Okay, so each have its own presentation and prognosis and management. So why we are classifying based upon its location is the prognosis and the management. So the prognosis and the management vary with the location. Okay, so first starting with the parenchymal. So what are its presentation? So this is the most common presentation. So the most common presentation of neurocysticercosis in children is the most common presentation in children is seizures. This seizure which is associated with neurocysticercosis is the preventable cause, most common preventable cause of seizure. Okay, here the seizure can be either focal or a generalized seizure can be present. It can be either a single episode or a multiple episode can be present. Third, the child can also present with fulminant encephalitis, which is a very rare presentation. The child will have headache, A child can have signs of raised ICP when they have a very big surrounding edema. Okay, so these are the presentation when they are present in the brain parenchyma. Second, when they are present in the intraventricular region, they will have this obstructive hydrocephalus, and they will have the signs of raised ICP. Okay, next, in the subarachnoid space, it is a very rare location and very rare presentation. They will present with the features of basilar arachnoiditis. This is basilar arachnoiditis. That is, they will have the symptoms like related to cerebral infarction, presence with the features of cerebral infarction, communicating hydrocephalus, and meningeal irritation. Okay. Next, we'll see its ocular. In ocular, they can present either in a vitreous tumor or in the subretinal space or in the conjunctiva. Here, the child will experience a poor visual acuity. That is, there will be a diminished vision when they are present in this ocular region. These are some of its clinical features of neurocysticercosis. Next, we'll see its stages. There are 4 main stages, which is called as Escobar's pathological staging. This stages we'll see mainly its important points and the imaging findings. Okay, so first stage is vesicular stage, second one is the colloidal vesicular, third one is the granular nodular, and last is final stage is nodular calcified stage. In vesicular stage, there will be a viable parasite with an intact membrane, so there won't be any host reaction. So the child will not experience much of the symptoms. So in imaging, you can see a cyst and a dot, and this is a cyst, and there will be a dot, this white color. I'll show it. This white color dot inside this, there will be, it's called cyst and dot sign. There won't be any edema, so they won't have any edema, and there will be a hyper intense scolex will be present. Hyper intense scolex in T1 weighted images. Okay. Next, in colloidal vesicular, here the cystic fluid will become turbid in nature. The cystic fluid will be turbid. The membrane will become thin and leaky. So it will lead on to the host reaction, which will finally form the surrounding edema will be present. Okay, here this is the symptomatic stage. Here this stage, the child will experience all the symptoms like seizures, a headache, raised ICP signs, everything. Okay. So in imaging, you will see in MRI there will be a hyper intensity will be present. There the cystic wall will have a ring enhancement. So this is the ring enhancement, which is a classic feature of neurocysticercosis, and they will be having this surrounding edema will be present in the colloidal vesicular stage. The third stage is granular nodular stage. It is the here where the cyst will retract. So here the cyst wall retracts and the edema will decrease. Here you can see in this image the green color one. So the cyst wall retracts and the surrounding edema will reduce here. So the enhancement will be persisting, only the edema will decrease. And the final stage is nodular calcified stage. This is the end stage. And here they will be having a calcified cyst. The calcified remnant will be present. There won't be any edema in the nodular calcified stage. So these are the 4 main stages of our neurocysticercosis. Next, we'll see on to its investigation. In investigation, the neuroimaging. So neuroimaging will be the absolute diagnostic criterion for neurocysticercosis. Okay, here scolex within the cystic lesion. The scolex within the cystic lesion, either in the MRI or in the CT, is a definitive diagnostic of neurocystic sarcosis. In CT, it will be shown as the scolex will be a hyperdense dot. It will be a hyperdense dot within a cystic lesion. Okay. They'll have other special findings or other special features of neurocysticercosis are one more thing, the main differential diagnosis. So the main differential diagnosis of this neurocysticercosis is tuberculoma. Another one is the metastasis. One is tuberculoma. Another one is metastasis. So we need to differentiate between the tuberculoma and the neurocysticercosis. So we'll see the definitive features of neurocysticercosis and tuberculoma. Here neurocysticercosis will be less than 2 cm in size, while tuberculoma will be more than 2 cm. The wall will be well defined one, which will be thin and regular, while in tuberculoma will be a thick and irregular one. Both will have the surrounding edema, but the edema will be more severe in tuberculoma compared to neurocysticercosis. Basal meningitis will be present in tuberculoma and not in neurocysticercosis. It is a very rare presentation in neurocysticercosis. The scolex is a characteristic feature of this NCC, not in tuberculoma. Multiple stages. So here we have seen the 4 stages. The child can present with either one stage. The presentation, the image can be either one stage or multiple stages can be present in the same child in the same MRI film. So multiple stages will be present in neurocysticercosis and it will not be in tuberculoma. The main location or characteristic point of neurocysticercosis, it will be present in the gray white matter junction. It will be present in the gray white matter junction 1, or it can be present in the basal ganglia, while tuberculoma, its usual location is posterior fossa or its base. Okay, so these are the main characteristic features of neurocysticercosis and tuberculoma, and we'll see its imaging findings. I'll write it here separately. This is neurocysticercosis and tuberculoma. In MRI, T1 weighted images, this NCC will be a hyper intense one, as we seen in the image. They will be having a hyper intense. In tuberculoma, it will be a ISO to hypo intense in T1 weighted images. This is another characteristic finding in which you can differentiate between NCC and tuberculoma. In T2 weighted images, in NCC, there will be a hyperintense dot or a hyperintense cyst, that is cyst with scolex. They will have a ring enhancement. While in tuberculoma, there will be a hypointense core. There will be a hypointense core with a hyperintense rim will be present. So this is the main characteristic and differentiation in the imaging. Another one, how you can differentiate by using, suppose sometimes you can't differentiate even in this MRI T1 and T2, then you can do MRS, that is magnetic resonance spectrography or spectrometry, sorry. In this, there will be a lipid peak in tuberculoma. So there will be a lipid or elevated lipid in tuberculoma, plus they will also have an elevated choline creatinine ratio. Third, they will also have an elevated choline Na ratio. Okay. Next, while in neurocysticercosis, these all will not be present. They will have a elevated acetate peak, acetate and succinate ratio or a succinate peak. They will have a elevated acetate by succinate peak. Okay, so this is how you differentiate between neurocysticercosis and the tuberculoma by the imaging way. Next, we'll see its this management. So in management, we have different varieties or different types of presentation of neurocysticercosis. So what is the management according to its presentation and according to its anatomical location? If you have a viable and a non-calcified single cyst, so you should have a viable non-calcified single cyst, then you give the treatment of choice here will be albendazole. Duration of treatment is for 10 to 14 days with the dosage is 15 mg per kg per day as a BD dose you have to give. If we have read in our pharmacology that albendazole will act with the, it will, what is it called, bioavailability will be more when they are being taken along with the fatty meals. So they should be given along with the meals. So this is the treatment of choice for a child with the single viable cyst, that is albendazole with a 15 mg per kg per day as a BD dose for 10 to 14 days. Okay, next, when a child have a multiple cyst, when a child has a multiple viable cyst, then you have to give a combination therapy. You have to give a combination of albendazole plus praziquantel. So the dose of albendazole is the same, that is 15 mg per kg per day, while this praziquantel is 50, it is 50 mg per kg per day. These both are given for duration. These both are given for a duration of 10 to 14 days. Okay, so this is the treatment of choice when the child have a multiple viable cyst. Next, when the child have a persistent lesion, that is even after taking this albendazole for 2 weeks. Next, I forgot this one thing, that is a follow-up image. When will you take the follow-up image in a child who are you treating with a neurocysticercosis? You have given albendazole for 2 weeks. Next, when will be the follow-up image? So the follow-up image will be after 6 months. So you can repeat the contrast enhanced MRI after 6 months, or when the before 6 months you can do when the child have the what is it called, the child have any symptoms of either neurocysticercosis or when the child is not improving with the present symptoms, then you can take the repeat image can be taken. So repeat image after treatment of NCC should be done at the interval of 6 months only. Before that, the child present with any symptoms, you can do the imaging. Fine. Next, so when you do the imaging after 6 months, when the child when you find the child to have a persistent this lesion, then what you do? You will have two choice. One, you can do a retreatment with this albendazole. You can do retreatment with the albendazole with the same dose, that is 15 mg per kg BD dose, for same duration, that is 10 to 14 days, as you treat this what is it called, single viable cyst. Next, or you can treat like this multiple viable cyst, that you can use albendazole plus praziquantel, the same dosage, that is 15 mg per kg. This praziquantel will be 50 mg per kg per day for 10 to 14 days, same as multiple neurocysticercosis. Okay, next, you can use either this or this. Okay, when the child has a cysticercal encephalitis, what you will do? This is a very rare presentation, but when the child presents with encephalitis, you have to give a pulse IV steroid. Pulse IV steroid you use here is methylprednisolone. The dose is 10 to 30 mg pulse dose, that is for 10 to 30 mg per kg per day for only for 3 to 5 days. Sorry. So you give this for 3 to 5 days. Only when the child is having an acute symptomatic edema, you use this pulse IV steroid. Next, after this, you can continue this steroid at a minimal dosage. So continue the steroid at a minimal dosage to prevent the episodes of this acute symptomatic cerebral edema in children with the encephalitis. So you continue the steroid in a minimal dosage for a long term. Okay, so this is about the treatment of choice for single viable, multiple viable, persistent lesion and the cysticercal encephalitis. Next is the prophylaxis, when the child have an seizure. Then how will you treat the seizure and what is the prophylactic advice you give? So you treat this anti-seizure prophylaxis in a child with neurocysticercosis with drugs like carbamazepine or oxcarbamazepine. Second choice, you can use phenytoin also. For a single lesion, next we will go to the duration, for how long you have to give. For a single ring enhancement, at a single viable cyst. For a single viable cyst, you give the duration for 6 months. If the lesion resolves on follow-up, you just give for 6 months, then you discontinue. When the child have a multiple viable cyst, or when the child has a persistent lesion or persistent cyst that is being present in the imaging, the duration will be a longer duration for about 24 months. Okay, this is 24 months and this is 6 months duration. So this is about the anti-seizure prophylaxis that you're going to give to a child with the neurocysticercosis. Once the child, in this example, for a single cyst, you give for 6 months, you repeat the image. There are no other lesions being present in the imaging. The child did not have any seizure episode. Then that is at least less than 2 episode has been present, then you can stop the drug. Whether the child having a multiple viable cyst or a persistent lesion is being present, or the cyst is being calcified, then you give the treatment for that is anti-seizure prophylaxis for about 24 months. Plus, once the child has also have episodes of more than 3 episodes, once the child has experienced more than 3 episodes on the anti-seizure prophylaxis, then also you continue this anti-seizure prophylaxis. You don't stop it abruptly. Understood? So once the child have more than 3 episodes, even without any finding on this neuroimaging, also you continue a longer duration of anti-seizure prophylaxis. So this is about the neurocysticercosis. If you write these much points for a 7 mark or a 5 mark question, it will be enough. Fine. Thank you. Next, we will discuss about brain tumors part 2. So because one of the student have put brain tumors part 2 in a comment section, so I'll try to finish it by this week only. Fine. Thank you. Kindly like, share and subscribe our YouTube channel. Let's